All right. Good afternoon, everyone. And I'd like to welcome you to our special Thursday noon conference. I'd like to welcome Dr. Ahmed Masri, who is an assistant professor of medicine at Oregon Health and Science University. Dr. Masri is a cardiologist who specializes in cardiac imaging, hypertrophic cardiomyopathy, and amyloidosis. He directs the Center for Hypertrophic Cardiomyopathy and co-directs the Center for Amyloidosis. He's trained in internal medicine at the Cleveland Clinic, completed training in cardiovascular disease at the University of Pittsburgh, and then spent 2 years at the University of Pittsburgh, supported by a grant from the National Institute of Health, focusing on cardiac imaging and left ventricular hypertrophy. Welcome, Dr. Masri, and thank you for being with us today.
Fantastic. Thank you, Nadeen. Thanks for the kind introduction and for the invite here to speak to you today. Um, it's a pleasure joining you. Let me see if this works. Okay, good. So those are my disclosures. I receive research grants all paid to HSU, and I will be discussing mavacamten and CK274, which are not FDA approved. And for those of you who don't know, it's this like being back in residency and actually, being back home. Uh, all of these individuals have been either co-residents or senior residents to myself, or junior residents, and it's really great pleasure being here. I'm sorry if I forgot anyone, but also there are a lot of friends and mentors who are currently at Methodist, so it's really truly an honor speaking to you today. And so I know we have a mixed audience here, so I thought I would just really try to target both some material for our fellows as well as some new exciting developments and why I'm excited about HCM. So the outline is the first part. We'll talk about the old stuff that a lot of you know, and then spend some time talking about the new things in hypertrophic cardiomyopathy. This is a timeline here, just showing you, how mature the disease is, as well as the innovation and advance that happened over the years, dating back to 1957-58, where the first case series was described, up until when surgical myectomy was actually, performed and by Dr. Morrow over there, as well as Dr. Brunwald, where he described all the hemodynamics of hypertrophic cardiomyopathy and why it's different from aortic stenosis and sub-aortic stenosis. And we, continue there all the way with echo development, MRI development, ICDs, all the way up to when we're right now in really exciting times where we have newer therapies for hypertrophic cardiomyopathy, which I will be discussing in details. Hopefully the videos are playing. I know that sometimes they come across over virtually, not, chopping a little bit, but really when you think about HCM, we think about thick walls, non-dilated left ventricle, hypercontractile or hyperdynamic function. No other clear reason for left ventricular hypertrophy. And always remember that we are ought to rule out phenomimics of it, because if we don't think about them, although they're uncommon, we tend to miss them. And so this is where you see here asymmetrical hypertrophy of the anterior septum here compared to infralateral wall, and here you see SAM, systolic anterior motion of the mitral valve. And this is a classic, essentially, phenotype for obstructive hypertrophic cardiomyopathy. And here you can see that what we call here the classic Y sign, where you have essentially LVOT acceleration or obstruction, as well as mitral regurgitation that is related to SAM, and that is over there posterior directed. Strain imaging can help sometimes. You would have essentially decreased strain at the bases, at the anterior septum specifically. And not to forget the other type, which is more often actually missed, which is non-obstructive hypertrophic cardiomyopathy, where you have essentially thickening in the heart without any other reason, but there is no SAM, there is no obstruction in the LVOT. And so when you think about it from a histopathological perspective, this is the classic description where you have the normal architecture of the nucleated myocytes there. And with classic hypertrophic cardiomyopathy on histopathology, you have disorganized myocyte disarray. And when on gross specimen, you have fibrosis, which we can see is replacing in the interstitium there. But this is not this is not found universally. That's why biopsy is not something that we typically do to diagnose hypertrophic cardiomyopathy. Myocyte disarray is not a universal finding in such patients. And this slide is from my friend and mentor Steve Heitner, where if you think about how many mutations we have in HCM, there are a lot of mutations, more than 1,400, 1,500 described today. The majority of them are in the myosin binding protein C and in the myosin heavy chain. So what we call heavy chain disease or mutations. And then you have a lot of other dispersed mutations in the thin filaments, in the troponins and tropomyosins, and a slew of other mutations. And the way to think about it, which that's I love this depiction here by Steve, where he thinks about cardiac myosin binding protein C being the brakes, and then your myosin being the gas. And any mutation in either of these genes would lead essentially to the phenotype that we see with hypertrophic cardiomyopathy. Again, I'm sorry if the videos are not playing well, but genetic testing yield relates directly to the phenotype itself. And when we think about HCM, the majority of patients have sigmoidal shaped septum. Some of them, all of them also have reverse curvature. And we see, quite often here we see apical HCM as well as the neutral phenotype there. And when we run genetic testing, and this has been published on before by many groups, the overall yield so far is about 40, 50%. It's the same here at OHSU. And we see it commonly that apical is almost all the time is, we don't find really genetic mutations. Same for neutral. But when we come to reverse curvature or sigmoidal, we have more luck typically there. And it's very, very common to have patients who are the first ones diagnosed in the family. Not to forget the mitral valve. The mitral valve in HCM plays a very important role. SAM is the hallmark of the disease, where you have obstruction in the LVOT for the blood flow trying to leave the ventricle, leading to wall stress and a lot of slew of other problems. But also don't forget that there are a lot of elderly patients with HCM. MAC creates a special problem, especially for those being considered for surgery. You have elongation of the leaflets, which we see a lot on MRI imaging that by themselves can cause problems. We've had cases as well as others of obstruction without significant hypertrophy. And also, abnormal papillary muscle is increasingly recognized in the era of cardiac MRI imaging as being a very common problem and encounter in patients with hypertrophic cardiomyopathy. Again, besides the mitral valve, we have the submitral valve apparatus to think about. These are two different patients where you see the papillary muscle is being slightly displaced there, but more importantly, its insertion is anomalous. Instead of inserting at the tips of the leaflets, they're inserting closer to the base. Here, the ventricle is dilated, so it's not causing obstruction, but that's unfortunately a bit late. While here, you can see how this patient had a high gradient and there was no SAM. The gradient was secondary to the papillary muscle insertion, where it is inserting at the base of the anterior leaflet. A very important distinction there is hypertrophic cardiomyopathy versus athlete heart. And there are a lot of features that can differentiate both of them. The most important things to remember, especially for our fellows, is when we talk about this, we're talking about a gray zone. We're not talking about someone who has a 2 centimeter heart, septum, and we're discussing athlete heart. The majority of athlete hearts essentially don't really go beyond 15 millimeter or so, 16 millimeter in thickness. And so when we talk also about athlete heart, we have to remember that the LV cavity is typically not necessarily dilated, but it is generous. While in HCM, the LV cavity is typically small. As well as whenever you have any diastolic dysfunction, any abnormalities there or marked left atrial enlargement, abnormal LV filling, think about HCM obviously and not athlete heart. With athlete hearts, typically you have some thickening, you have some enlarged ventricle, but otherwise everything else appears to be normal. And when we think about the presentation, there are a lot of buckets there. And the buckets can essentially move the patient from completely asymptomatic, even not having the phenotype, but just being genotype positive, to even being at high risk of sudden death. And sudden death does not always correlate with symptoms. It can be the first presentation in some patients. The most a troubling development for patients with hypertrophic cardiomyopathy, besides essentially sudden death, which can be a final event, is heart failure and atrial fibrillation, and those create a lot of morbidity for patients. And we'll talk about where mortality for these patients nowadays are sitting. And so when you think about features of it in the clinic, even without talking about imaging, this is one of the hallmarks of apical HCM Yamagashi type EKG, where you have deep T wave inversions, high QRS voltages there. And we've actually written a case about this one time in one of the electrophysiology books, where patient with this pattern, with history of hypertension on a couple of medications, kept being told that this is because of high blood pressure, until essentially, unfortunately, they are arrested and couldn't be revived. And so this is a very important pattern to remember also for the boards. And but really the hallmark of the disease when in obstructive hypertrophic cardiomyopathy is the fact that it's a dynamic process. Anything that alters LV cavity volume or contractility and afterload would lead to either increasing or decreasing of the murmur. The most common things we do in the clinic are Valsalva, standing while essentially having your stethoscope on the patient, as well as you can do hand grip and squatting maneuvers to see essentially how the murmur changes, and you can compare that to murmurs of mitral regurgitation. And this is essentially, if we are going to move to the imaging space with echocardiography, you can really study these patients' hemodynamics very carefully. Here is the LVOT gradient at rest. You can see where the velocity of the wave is, while when Valsalva starts, there is more dynamic LVOT obstruction, mainly because of SAM in this case. And then once patient stops the Valsalva and the intrathoracic pressure goes back to where it was before, they go back to where the gradient was at rest. And so when we think about how do we manage these patients, we broadly classify them into those with obstruction and those without obstruction. Unfortunately, patients without obstruction right now, we don't have a lot of good therapies for. We try beta blockers, calcium channel blockers in them, as well as, if they have decreased ejection fraction, we try standard of care therapies for any heart failure patients. We also rely a lot in diuretics in these patients if they continue to have issues despite being on beta blockers or calcium channel blockers. But besides that, we are limited. There was a phase 2 Maverick study of mavacamten in these patients, showed a signal for benefit there, and then we will be probably moving for the phase 3 in the next couple of maybe next year or so. But focusing on the a hallmark of hypertrophic cardiomyopathy, LVOT obstruction, you always start with either beta blocker, calcium channel blocker. If you look at the guidelines, typically you go with a beta blocker first. What we notice is that in young patients, they really don't tolerate beta blockers, and they almost always ask for a switch. And so we typically start with the calcium channel blockers in younger individuals. And in our practice, if those fail, we actually do try